So we should get going here so we can end on time. I am stepping into Dr. Ram's shoes in the introduction of our Grand Round speaker. And I'm happy to welcome Dr. Kate Herster here. She is an acting assistant professor here in our department. She works over at the VA as a staff psychologist. She got her PhD and her Master's of Public Health from the University of California System at San Diego State. And her research focuses on sort of social and cultural and environmental impact on health and health behaviors. And specifically, she's a PI on a grant currently looking at social and neighborhood factors on chronic disease in veterans with and without PTSD. So, welcome.
Thank you so much. I'm really excited to be here today to talk about some of my research. Today I'll be talking about the impact of context on health behavior, the importance of considering context and designing health behavior interventions, and really the exciting opportunities that we have to intervene at levels outside of individuals, levels like policy and community levels, to create perhaps more meaningful and efficacious and wide-reaching public health interventions. So what do I mean when I say context? The Ecological Framework here does a nice job of presenting what I'm referring to. It's something that we all really, I think, understand, that while individual level factors like knowledge and biology and so forth matter in determining health behavior, that factors outside of the individual are very influential as well. The social context is important, the organizations that individuals interact with, the built environment and the communities that individuals operate in and live in, and local, state, and national policies. All of these factors and the interactions among them are influential in determining behavior and health behavior. And I think a nice example that illustrates this very well is tobacco use. I'm sure that all of us here have seen in our clinical work and in our knowing the literature that tobacco use is influenced by things like neurochemistry and attitudes and beliefs and so forth, but also the influence of peers and families. Their behavior is impactful in determining tobacco use, as are the actions of organizations. So we've seen very clearly that when organizations such as campuses or hospitals ban tobacco use on those in those organizations, that influences behavior as well. We also know that at the community level, access to tobacco retail outlets influences purchasing of tobacco and behavior of smoking. And then we've all seen very clearly, particularly in the last decade, the impact and the powerful impact that policy can have with the tobacco use bans in public places and workplaces and so forth. And actually, really, there's a very large body of literature that demonstrates the powerful role of context for a number of health behaviors. And today I'm really just going to be focusing on a small window of that literature and talking about my own research. First, I'll talk about my graduate work where I examined multi-level correlates of indoor tanning behavior. And it's a really exciting topic. And then really switching gears to talk about multi-level correlates of healthcare use among farm workers, which was more my independent research that I did during graduate school. And then I'll finish up by talking about how I've taken my background in multi-level research to my current work within the VA and applying this more population-level work to clinical populations, veterans, in particular veterans with PTSD, to address their disproportionate disease burden. So I'll start with talking about the work I did with indoor tanning behavior. Throughout my graduate training, I was really lucky to work on my graduate mentor's NIH-funded study, City 100, which stood for Correlates of Indoor Tanning Among Youth, and it was conducted in the 100 largest U.S. cities to get a sense of what the multi-level correlates of this particular health behavior were, indoor tanning behavior, to identify areas for potential intervention. briefly, why was it important to study indoor tanning behavior among youth? Well, the epidemiological literature pretty clearly shows that using indoor tanning in youth in particular places people at significantly higher risk for developing melanoma, which is the deadliest form of skin cancer. And we also have seen that teen girls in particular are using indoor tanning at really high rates. And so it was important to address this public health issue of teens exposing themselves to this carcinogen at such high rates. This graphic depicts the 5 interlocking studies within City 100, and you can see that at the individual and sociocultural level, we conducted a phone survey with 6,200 parent and teen pairs in the 100 largest U.S. cities. So that got at the individual and interpersonal levels of influence. At the environmental level, we used mapping software, so geographic information systems, to quantify the presence of indoor tanning facilities in these teens' communities to see if that impacted the behavior of indoor tanning. At the policy level, we quantified the stringency of policies at the state level for indoor tanning, as well as the enforcement of those policies. And we also examined the compliance of indoor tanning facilities within those cities with their state laws. And we did this by having teen confederates, people who sounded like teenagers, call every tanning salon in the 100 largest cities, so that's 3,400 tanning salons, and do a really brief script to examine, would they need their parents to sign a consent and things like that if they were to come in to tan. And so it's a pretty big study, and I won't actually be talking about all of the various findings that we had from the study, and instead I'll be focusing on 2 of the primary domains, the built environment level and the policy level, because those findings ended up being really instrumental in our later efforts to translate the findings into public health intervention. So first, the built environment study, where we used fairly complex procedures to identify and map indoor tanning facilities in these cities. And we found what we expected, which was that teens living closer to an indoor tanning facility were significantly more likely to use indoor tanning, to indoor tan. And this was after adjusting for factors at the policy level, at the social level, and at the individual level of influence. We also, in this process, decided to collect some fairly simple statistics. We had, of course, the prevalence of indoor tanning salons in each of the cities, and we decided to compare the prevalence of tanning facilities to 2 other ubiquitous establishments, Starbucks and McDonald's. And as you can see here, indoor tanning facilities on average outnumbered Starbucks and McDonald's in our country's cities. and we published both the complex mapping findings as well as the very simple statistic in the American Journal of Preventive Medicine. And guess which findings were most widely picked up by the media and used by healthcare organizations to advocate for change? The simple statistics comparing indoor tanning facilities to Starbucks and McDonald's. Which brings me to my first kind of key consideration in doing this kind of work, which is that it's important to identify research findings with broad audience appeal that are simply conveyed. And that was definitely the case with our tanning salon, Starbucks, McDonald's comparison. And to disseminate those findings beyond traditional academic audiences. So we didn't just stop with the manuscript and let it sit in the journal. We identified what the key findings were that we wanted to get out to the public and to organizations that could advocate for change, and got that message to them. The next component of City 100 I'll talk about is our efforts to quantify the stringency of indoor tanning laws. And you can see that at the time of the study, only 28 of our states had indoor tanning laws at all, and 21 of those had specific youth access restrictions. And primarily these were requirements to obtain parental consent to have a teen indoor tan. And at the time, no state laws had banned indoor tanning for those under age 18. And what we found was we examined, as with the built environment factor that was so influential, we expected the policy level of influence to be associated with indoor tanning behavior at the individual level as well. Well, in our multivariate analyses, that was not the case. Having a youth access restriction law was not associated with indoor tanning behavior. And based on the findings from some of our other components of the study, what we realized is that parents were providing consent for their teens to tan, and so that was sort of the take-home message we had from that. In summary, with City 100, we found correlates at the individual level, at the social level, at the built environment level, and we did not have findings at the policy level, but we had important implications from what we found regarding our policy level correlates. And we published all these findings again in American Journal of Public Health, but we didn't stop there. What we did was we identified, okay, what are the most salient messages going to be? How can we translate this work into large-scale public health intervention that will reduce rates of indoor tanning among youth? And we centered around two key themes, and these are the themes I've already discussed today, which is that tanning salons are highly prevalent, which encourages tanning among youth, and that the current laws as written are not working. And when we looked at these two messages, both of which we thought were really important to get out to the public and advocacy organizations, we realized, though, that the implications, we had to sort of weigh the feasibility of these implications. And the first, which is that tanning salons are highly prevalent, well, we realized very quickly that we wouldn't be able to alter the built environment. This is a national study, and we aren't going to be able to change zoning laws and so forth to reduce access in that way. But this, finding that the current laws are not working to reduce indoor tanning behavior, that had the most sort of salient implications, as well as those that could be easily translated into action. And so we identified a singular goal from our research, which was to ban indoor tanning for minors and to have that become state law. And this brings me to my next sort of key consideration to highlight, which is prioritizing intervention targets. When implications suggest it, prioritize higher order interventions because of reach and public health impact, which is why we went ultimately with a policy-oriented goal. Likewise, consider feasibility of changing a contextual level factor and setting priorities. So again, why we selected a policy-oriented goal as opposed to a built environment change-oriented objective. So in order to obtain our goal, hopefully, of banning indoor tanning for minors, we sought supplemental funding from NIH to engage in dissemination activities oriented around this goal of policy change. And you can see here I've included the key target audiences for our messages in hopefully creating this change. And you can see that policymakers were really at the center of our efforts. We also communicated our findings to the public and to lobbyists and researchers, but we really highlighted two important audiences that we hit really hard, which was the news media, because of their ability to sort of call the public to action, and health organizations that really are invested and equipped to take research findings and those personal stories and translate them into policy change, and they're very skilled and experienced with working with policymakers. And the latter was really key because when there are actually laws that prevent using federal funds to lobby directly for legislative change. And so we weren't ever able to get directly at our target audience, which was policymakers. We had to go through the public via the news media's sort of call to action and health organizations. Our primary method of communication was to develop a website, and you can see it's hopefully viewed as a sort of user-friendly website, not very academic, and we really tried to make it sort of a fun website to use. We included information about the connection between indoor tanning and skin cancer, and this included personal stories from people who'd experienced melanoma because of indoor tanning. We also included some of our key findings from City 100 that we wanted to highlight. And then we included a section where individuals could go and learn about what they could do to advocate for change. If they were teachers or parents or teens, those guidebooks were tailored to those audiences. We also included interactive statistics pages where people could go and look up the information on tanning facility prevalence in their city, and as well as their state laws. And I've included the statistics for Seattle here, and you can see that as opposed to the national average where tanning facilities outnumbered McDonald's and Starbucks, not surprisingly, Seattle actually had twice the number of Starbucks and tanning salons. So not surprising. But you can see that providing this kind of data really allowed individuals within cities and states to know what their town, their state was up to, and then create tailored sort of action plans from that. So what was the outcome of all of these efforts? Well, I'm really excited to report that in late 2011, California became the first state to ban indoor tanning for minors. And of course, and I'll note actually that many states and jurisdictions have since pursued this as well, and that includes Washington State, which is currently considering this as well. And without a doubt, many things went into passing this indoor tanning ban in California. Years and years of work, but we really were proud to know that our City 100 findings were used to promote and push forward this legislation. And our partners, the American Academy of Dermatology, their advocacy arm, and some of our other partners really said over and over again that City 100 findings were important in bringing forward this change, and particularly over and over again cited those very simple tanning salon, Starbucks, McDonald's comparisons as being really helpful in framing the issue for legislators. So bringing me now to another key consideration in doing this kind of work, which is that selecting the primary dissemination audience involves making difficult choices about who will receive the study messages. And we really focused all of our efforts on policy change in this, meaning that our resources were spent there instead of directing our messages toward teens and parents, for example. Those were not audiences that got our messages very often. And we decided to take the policy-oriented approach because we thought we'd get the most sort of public health bang for our buck. And I'm excited to report that the process of this dissemination activity was just recently published in Translational Behavioral Medicine. And you can see this paper if you'd like to sort of see more about the lessons we learned from this process. So I'm going to switch gears now and talk about my independent graduate work where I studied multi-level correlates of healthcare use among farm workers. So as many of you surely know, farm workers provide the large share of our fruits and vegetables in this country. They're a really important part of our labor sector in this country, and they face disproportionate disease burden and disproportionate rates of mortality. And in line with that, also have disproportionately low rates of healthcare use. And at the time that I conducted this research, very little was known about what factors would facilitated or discouraged healthcare use in this population that really needs to be getting healthcare. And so I sought funding from the Department of Health and Human Services to conduct this research, which at the sort of the core component of the study was the National Agricultural Workers Survey, which is a nationally representative sample of farm workers, and it had information about healthcare use as well as individual level factors that would be important to examine. But I also coupled the survey with contextual level factors that I thought might be important. And I won't go into all of them today, but the primary one that I was interested in was healthcare service availability in these farm workers' communities. And I focused on the federally qualified health center system because the federally qualified health center system is a national part of our public safety net, and it's designed really to serve underserved populations, and they have a particular priority within the system of serving farm workers. And so we examined, in addition to these individual level factors, whether proximity to an FQHC as well as resources, staffing and financial resources for the FQHCs at the county level influenced healthcare use among farm workers. And we expected it to. And similar to how City 100 went, this contextual level factor was not associated with healthcare use in the farm worker population. And of course, that sort of had us pause again and think about what the implications of this were. We also, though, did find many factors that were associated with healthcare use in our multivariate analyses. We found that healthcare use was significantly lower for migrant, undocumented, and uninsured farm workers, which is essentially what we expected, as well as those with poor access to transportation. And so, as I mentioned before, the study was funded by the Department of Health and Human Services, which runs the FQHC system. And so they were really invested in figuring out what to do about these findings. And we published our findings in the American Journal of Public Health. But again, just like with City 100, we went on and partnered with the Department of Health and Human Services to identify which of the many findings were going to be most salient and easily translated into organizational policy change and most salient to decision makers to sort of make this happen. So I developed, in addition to the manuscript, I developed a policy brief in partnership with the folks I was working with at the Department of Health and Human Services. And we, again, identified really sort of clear messages about what we thought needed to change. And this included being more strategic about resource allocation to these more vulnerable farm worker subgroups that we'd identified in this work. And we're very specific in suggesting and recommending insurance and immigration reform as part of this, given what we found. And I'll note that, unlike City 100, this was not, these were not funded dissemination activities. This was something that I had to do on my own time, which is what most of us have to do. And so that really brought home one of these other key considerations in doing this sort of work, which is how critical it is to identify partners in this sort of contextual level intervention work. I identified really invested partners at the Department of Health and Human Services whose whole lives and careers are dedicated to trying to get farm workers to health to improve. And so they were really excited to partner with me and had the avenues to translate my findings into action. Switching gears again now, I'll talk about the work I'm doing currently within the VA and how I'm translating that background I have in multi-level research to the clinical population I currently work with in the VA, which is veterans with PTSD. So I came to the VA about 3.5 years ago for clinical internship, and right away I started working with veterans with PTSD. And very quickly I realized this was the patient population I wanted to work with long term. And I also started to notice that the guys I was working with, primarily men, really faced, in addition to their mental illness, they also faced disproportionate disease burden. I would be leading a group and I'd be looking around the group room and see that most of the guys in my group were overweight or in many cases obese, and also had diabetes and cardiovascular disease and hypertension. These were all guys I really cared about a lot and decided very quickly that I wanted to begin to study how we could improve this issue. And indeed, it was not just my sort of clinical observation that veterans with PTSD face really significant chronic disease burden, but this is really substantiated in the literature. So by way of background, I want to acknowledge first that in general, veterans are a really important priority population regarding public health intervention. Veterans have poorer health than civilians, and that's been known for a long time. My colleague Karen Lehavot and I recently published companion papers really demonstrating this using national data that on a host of health indicators, veterans, both male and female, have significant disease burden as compared with the civilian population. And then within the veteran population, those with psychiatric conditions are at even greater risk for illness, and this includes PTSD, which places veterans at increased risk for cardiometabolic illness, so overweight, obesity, diabetes, cardiovascular disease, and increased risk for mortality. So really important public health issue here. And why it is that PTSD leads to this cardiometabolic illness is, due to a number of complex factors, including the direct physiological effect of stress on the body, but it's also due to health behavior deficits, so potentially a more modifiable factor. And it's sort of really well documented that PTSD is associated with increased risk for smoking and alcohol use, which are, as we know, bad for the body. But there's a small but growing body of literature that also shows that PTSD is associated with poor engagement in health-promoting behaviors like physical activity and diet. And of course, those behaviors would be really critical in preventing and reducing the burden of cardiometabolic illness in the population. And, this was, when I went to the literature, I was comforted. This is exactly what my patients tell me all the time, which is that they have a really difficult time making behavioral changes like increasing their activity and improving their diet because of PTSD symptoms. For example, hypervigilance, so always being on alert, makes it difficult to go grocery shopping and to get out into your community and be active. And certainly this is what my patients have told me, but at this point, there's very little in the literature that has looked at what factors really get in the way of physical activity and healthy diet in the population of veterans with PTSD. And so I set out as one of my first sort of studies in this area to examine the correlates of health behavior, particularly physical activity and diet in veterans. And so I'm the principal investigator of a survey study that's funded by the VA MIREC and VA HSR&D Center of Excellence, the local centers here. And this is so we've sent actually the survey to 2,000 King County residing veterans. And these are all Seattle VA patients because, again, we're really wanting to target this clinical population. And about half of these are randomly selected veterans, but we did sort of stratify our recruitment so that about half of the sample had a diagnosis of PTSD and half did not, so that we would be able to examine what factors differentially correlate with health behavior for those with and without PTSD. And we're looking at a number of potential correlates of health behavior. Of course, given my interest and really the important role I think this plays, we're looking at the perceived neighborhood environment as a potential correlate of activity and diet. We're also looking at the social context, general social support as well as social support specifically for these behaviors. And of course, individual level factors like psychological functioning and other health risk behaviors like tobacco use and pain and chronic medical conditions. We also are going to evaluate the objective neighborhood environment. And so, of course, this was a mailed survey, and so we have the addresses of our participants in the study that we can use to understand their neighborhood environment. And of course, we were clear with our participants when we were recruiting them that we would be linking information about their neighborhood to their survey responses using a random subject identifier. And one of the key neighborhood characteristics that we'll be looking at as far as objective neighborhood measures is walkability. So basically, how conducive is your neighborhood community to being active? And one of the features of walkability is the presence of connecting streets. It's kind of a simple concept, but it can really make a difference in how walkable your community is. So, for example, you can see that the image on the left and the right both they're equivalent distances between A and B, points A and B, as the crow flies. But when you look at how a pedestrian would experience that walk, you can see that the distance in the image on the right, the community on the right, is a far more efficient route, which for the most part would promote activity within the community because it's efficient, and that's due to the higher level of connecting streets. This concept of walkability also incorporates the quality and presence of sidewalks in your community, the attractiveness and the attractiveness and destinations along routes within your community. And just, very quickly, you can see on the left is a very unwalkable community. There aren't sidewalks at all, and there aren't many destinations of interest, and it's not particularly attractive. So this is going to be a community you're not going to want to walk around, as opposed to the community on the right, which really is a pretty lively urban setting. But you can see, possibly you can see that the sidewalks are really wide. There are attractive buildings, places of interest, destinations that you'd want to go to. The streetscape on the right is going to be a more walkable community. It's going to get people out and active more likely. So we'll be able to evaluate, this correlate of physical activity and see whether this thing we've seen influences activity in the general population, whether that influences activity in the veteran population, and particularly how it operates for those with and without PTSD. In Seattle, we actually live in, I saw this on the internet last night, that we're in the 6th most walkable city in the country, which is pretty nice. But you can see in this map that King County has great variability as far as walkability is concerned. And you might recall that we recruited veterans who live in King County from the VA, and so we'll be able to examine whether this factor of walkability influences activity in our population. We'll also be able to examine the local food environment as a correlate and the social environment, so things like presence of crime and poverty in the neighborhood. And we'll be doing all of this using geographic information systems, the mapping software, as well as data from the US Census. So we've now collected data from our survey study. We have surveys still coming in, but we've entered the data for 500 of our veteran respondents. And I wanted to highlight some of the preliminary findings just very briefly. And I wanted to start with this really startling and concerning finding, which is the significantly and substantially higher rates of obesity in veterans with PTSD. You can see that in the green part of the bar. And this was consistent with the literature, but of course concerning to see it reflected in this clinical population of people we serve. And in line with that, veterans with PTSD also had higher medical comorbidity, functional impairment due to physical and mental health issues, chronic pain intensity, substantiating again what we've seen in the broader literature. And also, conversely, we saw so far in our study that social support is significantly lower for veterans with PTSD. So again, really high rates of illness and lower rates of this sort of buffering effect of social support. And I think really making clear that we need to do something to address this issue. We've also begun to examine how, as I said before, correlates of physical activity differ for veterans with and without PTSD. And so far, what's showing up is that social support is facilitative of physical activity only for veterans with PTSD. The association was non-significant for veterans without PTSD in these stratified analyses. So social support is showing up as a very important potential mechanism to improve physical activity in the population of veterans with PTSD. Regarding neighborhood level correlates, the perception of neighborhood surroundings being nicer and more pleasant was significantly associated with physical activity, again, only for veterans with PTSD. So again, pointing out that there may be unique barriers and unique facilitators of activity that we can capitalize on if we want to improve these health behaviors in the population. And this was the finding that I thought was probably most consistent with what I see in my patients, which is that high perception of crime in the neighborhood environment was significantly associated with reduced engagement in activity, and again, only for veterans with PTSD. And this, again, as I said before, my patients are always telling me that their fears about safety are getting in the way of being active. Lastly, as far as the preliminary findings go, I wanted to highlight, we did ask our veterans in the sample how they would like to work on their physical activity and diet. And by far, veterans with PTSD acknowledge that they would like to work with other veterans to make their behavioral changes as opposed to those without PTSD. So again, really highlighting that social support and particularly veteran peer support may be an important way to make some of these changes. So I hope I've made the case today for something that I think is really clear, which is that a behavioral weight management intervention is needed for veterans with PTSD, and that intervention would likely need to be tailored to the unique barriers that we're seeing in the population. So I'll be closing today by talking about some preliminary thoughts that I have about such a weight management intervention. And these are some of the sort of proposals I've made in a career development award that I'm currently applying for. And of course, I'm going to be highlighting some of the considerations I'm making regarding the contextual level of influence. So one of the first things I wanted to point out is that being in a system like the VA, it can often be the default to think about doing an organizational level intervention, along the lines of what I've been talking about for the first half of my presentation. Being in a nationally integrated healthcare system means that you can make policy and organizational changes that have wide reach potentially. And that's definitely where my mind went first with thinking about how to do something about this issue. But I stepped back and started to think about the fact that with a powerful healthcare system like the VA, you can often forget that the patients we're working with are spending the vast majority of their time, well, at least we hope they are, in their communities. And so especially when I started seeing the preliminary findings from my survey study regarding the real struggles that veterans with PTSD are having being engaged in their communities, you'll see in a moment that I'm really thinking about this intervention as one of the key components that would be important is to integrate an emphasis on improving veterans with PTSD, their ability to interact within their communities. Just like the messages I talked about earlier as far as considering the feasibility of changing a particular contextual level intervention, or factor rather, it may be feasible to operate at the organizational level. That seems feasible, but maybe not as meaningful. And as far as changing the built environment, that is absolutely off the table. This is a clinical population that's geographically dispersed across the King County region and beyond. And so really in this instance, what we're talking about is not changing the built environment, which is hard enough to do for a singular neighborhood, but really talking about how veterans interact with their communities and cope with the stressors that their communities provide and their symptoms of PTSD provide. In particular, again, based on my findings and my conversations with patients, I think social support mechanisms are really poised to help facilitate this orientation around improving veterans with PTSD, their interaction with their communities. And I'll talk about how I'm thinking about doing that in a moment. The last point I want to make here is that, again, so in this case, I'm really talking about a more traditional health behavior intervention, what we're often doing. So that is the case, but what I have to acknowledge and remember in delivering such an intervention within a system like the VA is that the organization can change, and it can change in really significant ways. And so even when you're doing an individual level intervention, it's important to measure and keep track of the larger context of organization and how that might be changing and influencing your intervention and your patients. So I've included here a graphic depicting some of the things I'm considering for this weight management intervention for veterans with PTSD. And I'm calling it Promoting Recovery by Encouraging Veterans to Adopt Improved Lifestyles, Peers Prevail. So having peers promote not only lifestyle change, but also mental health recovery. And on the left, you can see here that a big chunk of the intervention would take place within the healthcare system. So a very traditional health behavior intervention where topics like goal setting and motivational interviewing and behavior monitoring and so forth are part of the intervention. I'll point out that I'm considering it really important to integrate this intervention into the mental health care setting so that it's experienced by the patients as being consistent with and really part of their PTSD treatment. And of course, this traditional health behavior intervention would include an emphasis on tailoring the information to address the unique barriers for veterans with PTSD. But you can see here that on the right, I've included an element that's all focused on integrating veterans with PTSD into the community setting to improve their health behavior, and that this is almost entirely facilitated by peer support. And this would be other veterans with PTSD who know the struggles, who can help really credibly facilitate the reintegration into the community. And this would be through conversations by phone, but also by facilitating and organizing actual activities such as walking groups and so forth. And ultimately, what the goal of this would hopefully be would be to, of course, improve physical activity and diet, but also PTSD and depression symptoms. We know that exercise and being engaged in one's community is important for mental health. And so hopefully this intervention would improve those areas as well and increase things like self-efficacy. Ultimately, the distal outcomes that we'd hope to see would be, of course, weight loss and improved quality of life. But again, these are preliminary plans and essentially ways I'm thinking about how I can take what we're seeing in the barriers for veterans with PTSD and integrating this into an intervention that really considers context as opposed to changes context. So this brings me to my final key consideration that I'd like to highlight, which is that communities know the contextual issues that most affect them. If I had not been able to listen to the patients I work with for the last several years and hear really their true struggle with integrating, with making behavioral changes, whether that's physical activity and diet or larger behavioral changes, I probably would have missed the mark with thinking about how to improve their health. And they have been very generous in telling me what matters most to them. And I think it's important that we consider the voices of our communities that we're trying to help. I hope I've made a case today that context is important and that it can have really large impact on behavior. And that this is true. Obviously, I've focused mostly on talking about public health interventions, but I really believe this is true for our patients as well, that we can have we can validate our patients' experience if we understand the context in which they're living and really work with them to identify how can they change their context or improve at least the way that they're interacting with their context. And in closing, I just, and in line with what I've talked about all of today, which is the really powerful impact of community, I want to acknowledge that this kind of work really takes a village, and I want to take a moment to acknowledge my village. So thank you very much for your time. And any questions? Go ahead.
Did you get, in the first study or effort you talked about, did you get pushback from the tang bed industry?
Oh yeah, thank you for bringing that up. Absolutely, actually. There's a lot of mention on the Indoor Tanning Association is the indoor tanning lobby. And they're a very powerful lobby. And they talked a lot about City 100, and they weren't very happy with what we did. Luckily, they did not, know about our activities, particularly when we were doing the Confederate compliance assessment until afterward. But they were particularly upset about that part of it. But they did not prevail in this in this instance, which is good.
About the strategies, back to the veterans again, the strategies of encouraging and supporting them to be involved in their communities. How does that take place?
Well, I'm really glad you brought that up, because I kind of had to talk quickly through this. But one of the things that I think will help with that is the fact that the intervention would be embedded within the mental health care setting, and so really, PTSD treatment in general targets community reintegration and actually makes as an explicit goal coping with anxiety and learning to cope with anxiety as you approach triggers for PTSD in your environment. And so in particular, I think that integration within that mental health treatment context would mean that they were getting those messages outside of the group, outside of the weight management intervention, as well as integrating those kinds of messages into the intervention itself. And part of that involves coping with anxiety more generally and those sorts of things that come up.
And I was just wondering how the institution of the VA have they welcomed your feedback in sort of gearing the services in keeping in mind these barriers unique to PTSD?
Yes, thank you. Yeah, that's a great question. So actually our leadership at the VA within outpatient mental health, where I work, has been very supportive of really focusing on lifestyle interventions. We have, it's not a weight management intervention, but we have a really wonderful and wonderfully received lifestyle change intervention that we offer already in the clinic. It's a 12-week group that focuses on physical activity and diet, as well as other health behavior change areas. So they've been very supportive, which is great.
I was just wondering, the patients with PTSD have really high comorbidity with chronic pain, and I think it's brilliant to do the physical activation and the weight loss intervention with them. I was thinking for a lot of them, they may actually have good reasons to be so active.
Mm-hmm.
How are you handling that within the program?
Well, so the program is really theoretical at this point as far as this intervention, but that's a very good point. And actually, in designing the intervention, as I hopefully am able to move forward with it, I want to bring in the input of people who are really experienced with addressing chronic pain and activating people within that context. And so that's something that I'll need to consider, absolutely. As we saw in the preliminary data that the rates of chronic pain were higher in our veterans with PTSD. So that's going to be very important. Anybody else? Well, thank you so much. It's been really great talking with you all today.